All right. I want to welcome everyone here to Cleveland EMS. I want to talk about some of the positive changes and the care that we provide for our community. So far this year, we've implemented several new programs, and one, as of November 17th, we have implemented automated ventilators to all of our ambulances, which increases patients' chances of surviving significantly when they suffer any type of respiratory illnesses. So, along with that, June 4th of this year, we implemented whole blood transfusions in the field, and we've administered that 46 times, and we've had a 70% increase in survivability due to that. So with these automated defibrillators, I want to get back to, within the first 6 hours of deploying those ventilators, we utilized it for the first time and had a significant impact in the patient's condition. With that being said, I also want to mention that due to the mayor's initiative on investing in public safety, we have 27 new cadets who are all paramedics, and for the first time in decades, EMS will be fully staffed in the field with paramedics to administer life-saving interventions to the citizens and visitors here in the city of Cleveland. So I want to pass it along now to the union, who will speak briefly about their take on positive changes here at EMS.
I'll keep it real quick. My name is Dave Jockers. I'm the first vice president for CARE, Cleveland Association of Rescue Employees. We represent roughly, with these new 27 cadets, close to 300 EMTs, paramedics, and dispatchers in the city of Cleveland. Working with this administration and Mayor Bibb over the last couple of years has been a whirlwind of positive changes, not just in the field, but also behind the scenes. We just settled a great contract with the city this year, and we've got a lot of excitement. With these new ventilators, I had one of the paramedics off of Medic 30 was up at headquarters yesterday, and he was talking about using a vent for the first time on Sunday. He said as soon as he put the person on BiPAP, it was just game changer. The patient immediately responded well to it. So CARE is very supportive, and obviously another 27 paramedics starting yesterday is a great sign of growth and improvement here in the division. And CARE looks forward to continuing to work with Mayor Bibb and the administration. Thank you. Sharon?
I'll just add to that. So now we're playing a key role in the continuum of care. We're bringing evidence-based medicine right to where the patients first had their injury or illness. So our initial care, those few seconds and minutes, makes a major impact on if the patient is discharged from the hospital. So like was already said, we're using this new life-saving equipment within hours and within days, and it's saving lives. There was another instance where we had a patient with a head injury, and the ventilator is also neuroprotective because it's important for the patient with a head injury to not get too much oxygen, but also not get too little oxygen. So the patient with the head injury was intubated, put on the ventilator, and had that neuroprotective support. So again, we are really happy to work with the city. We're really excited to have this equipment and to give this equipment to the citizens to save lives.
Good morning, everybody. My name is Rob Moyers. I'm a sergeant with our education department. I was tasked with training our members in ventilators. There's not a whole lot of pre-hospital ventilator use. A lot of that has to do with ICU, long-term critical care transport. Our members got 2 separate training modules. They got it from the actual company Zoll, and then retrained them, narrowed it down to what our protocol does. A few things that the ventilator does for us. We had talked about neuroprotection. There's something called lung protective ventilation that dials in the exact amount of air that somebody needs. So we go off of ideal body weight. height, gender, and we come up with a formula to give that amount of air. And these ventilators can give that consistently. Obviously, we have patients who are ventilator dependent in the city, whether they're coming from a home or a nursing home. We can now just continue that standard of care for them. Previously, if you can see that bag over there, that was our ventilator for the last 50 years. Now we have something that is mechanical and hands-free. They had mentioned BiPAP, which is a new treatment for us in the city. So if you have a lung problem, lung disease, and you're a significant emergency going on, we can use BiPAP to help them breathe and oxygenate themselves. And as you heard, that was actually the first use of the ventilator within hours of deployment. And finally, when we talk about cardiac arrest, we've had great strides in cardiac arrest and returns of circulation. A lot of the science right now is talking about ventilating people after they get a pulse. And using that lung protective ventilation, they're actually seeing improved neurological outcomes. So not only do we have devices to improve the actual return of spontaneous circulation, but then we can basically deploy ICU level care in the pre-hospital field and try to get better outcomes for our patients.
Do a little demo or the Q&A first?
You want to give a little demo? That makes.
Absolutely. Can I borrow somebody here to ventilate?
Sure.
Okay. So, for those of you, this is a lot of air to put into somebody's lung. We don't need all of this. We do have a piece of equipment that allows us to kind of dial in the tidal volume for lung protective equipment. So I'm going to have Sergeant Kozel here bag this person for us. And I'm going to show you how quickly that this is deployed. So the first,
You guys gotta move your cameras to get closer, feel free.
so we would hook all this equipment up. I'm going to turn it on. The good news is we're already ventilating our patient. So now, if Commissioner Wheeler, can you give me a height and a gender of a patient?
5'5", female, about 130 pounds.
5'5" female. We have a chart here that does the math for us. I'm going to go 5'5" female. That is 340 ml. So I'm going to select my patient. I'm going to do 2 tests to make sure that this is going to alarm me if we have a problem. Now I know that it can work. I'm going to dial my tidal volume down to 340. Actually to 100. And we're going to hook this up to our patient. And it is that fast. And now we're ventilating our patient. You can see how quiet this is. And it's delivering 100% oxygen at the desired volume, lung protective ventilation for our patients.
Anybody got questions?
Yeah, I just wondering, what is a 911 and between the EMS, what is the difference? If
Okay.
people call, people call 911,
Yes.
call EMS, what is the difference between this car, this emergency car?
You mean like, so I think when they call 911, they ask for police, fire, EMS, what do you need? So if the patient's on the phone, they're saying, I need an ambulance,
Uh-huh.
and then they'll dispatch an ambulance.
Oh, okay, but my question is, why people choose you and choose the 911 emergency?
Wait.
Oh, did you come to my
Yeah,
question?
I'm sorry, yes, I do. So we are the provider for
Uh-huh.
911, the medical service for the
Okay.
city of Cleveland. So when they call 911, they're calling Cleveland EMS.
Okay, the same, okay, thank you.
Mhm.
It's my understanding that Cleveland City Council approved funding for the ventilators in October 2024. When were the ventilators acquired and what took so long for you guys to get them?
So after they approved it in '24, the ventilators, once we put in the order for the ventilators, it took a while for the ventilators to go through the whole procurement process. So once they were ready through Zoll, they arrived here at Cleveland EMS, I want to say the earlier part of this year, probably about March of this year. And then after that, we started the initial training in late April, early May. And then we did another initial training in, I want to say, late September. And we wanted to make sure that everyone had all the training they needed for this to be a successful venture. So as far as time, it's the normal time for procurement and for the manufacturer to get us the equipment that we needed. So it wasn't really a delay.
Is everybody trained in using the technology?
Yes, everyone's trained. As of, what was that?
It's the second week in November.
Second week of November, everyone was trained.
Yeah, in addition with the vents, they normally don't get an order for as many as we did, so that took a little while. And like Sergeant Moyer said, they aren't used very often in pre-hospital care, so he had to go through the process of rewriting the protocol. Or not rewriting, but
Creating.
creating a protocol. So when he got the vents, that's when he could start creating the protocol. 'Cause you have to see what they can do before you write the protocol.
How many are you staffed with? Does everyone have one, or how does that work?
All of our 25 frontline ambulances have a ventilator.
Can you walk us through a scenario when it would be necessary to treat someone using this?
Okay, so say for instance you have a history of COPD or asthma, and you're having significant respiratory distress. And normal treatments like albuterol and other breathing treatments aren't working. We can supplement your ventilations with these ventilators to give you optimal lung protection. So that's one of the uses. And the other one is for individuals suffering from cardiac arrest. And one of the things that happens in cardiac arrest is you want to make sure that you're not overventilating or underventilating. And this piece of equipment makes sure that they're getting the optimal ventilation to increase their survivability.
Thank you.
Rob, do you want to touch base on barotrauma and cardiac arrest?
Yeah, just to add to what the commissioner said, underventilating, obviously you're not getting enough oxygen, but overventilating can cause trauma to the lungs, and it can actually stop blood flow returning to the heart. So we do have a device on our cardiac monitor. There's a little blue thing there. It's a ventilatory feedback device. It tells us what tidal volume and when to breathe, but it relies on human training, and you're never going to get the exact amount, right? This is going to give you the exact amount every single time. And just by going from the National Institute of Health, the use of ventilators and lung protective in ICUs has been showing that increased neurological outcomes. So we're basically delivering that care in the field before they even hit the hospital doors.
That's great.
We also pick people up from nursing homes that are already on ventilators. So our ventilator dependent patients, we used to take them off the ventilator and then bag them manually with this bag valve mask. So having the ventilator, being able to match their settings and taking them off their ventilator, putting them on ours, matching the exact settings is safer and more comfortable for those patients.
Is this something that could help save a life if somebody has suffered a stab wound or a gunshot wound or any sort of violent injury?
Well, anyone is suffering from any type of respiratory distress, no matter what it's from, whether it's traumatic or something that's a chronic condition, that the use of the ventilators would definitely increase their chances of surviving.
So as of last week, I believe it was, these are in effect.
Yes, as of the 17th of this month, they've been deployed on all of our frontline ambulances. And we have several in spare in case one goes down, that we can replace it immediately, and we don't have to, no one has to go without a ventilator, because a piece of equipment like this is essential that everyone gets the opportunity to the chance of increasing their survivability.
What does the combination of having this with like whole blood transfusions mean? And to like what Lucas asked, maybe explain how that would work in like a gunshot or like a crime victim perspective, having the two together.
So someone, say for instance, someone suffered a gunshot wound and they were having significant respiratory distress, or they weren't breathing at all. For one, it frees up paramedic to do other interventions. But Secondly, it increases the chances of them surviving by giving them the optimal ventilation and not overventilating or underventilating, therefore giving the right amount of oxygen return to the bloodstream so that ultimately it protects the organs from failure and it protects the brain from ultimately dying.
How much has it meant to all the workers on the field to have this new technology that better outcomes can happen from this technology? Can we just talk a little bit about like how the staff, how the EMS workers have responded?
Well, once everyone knew that the ventilators had finally made it here to EMS, they were excited and they wanted to know what the delay was. They were ready to start using it right away. But unfortunately, because they needed to go through training and we wanted to make sure that everything was done in a proper fashion to make sure that our room for error, our margin for error was very low, that we had to wait. But as soon as they were all deployed, everyone was absolutely ecstatic. And they still are, because this is something that a lot of paramedics across the country wish they could utilize.
Talking with our membership, I mean, they tell us, they said they're really excited to be working here. They're just happy and glad that the commissioner and the mayor has funded these advancements for us, and they look forward to it. It's new toys for us to get to play with. I mean, I've been on light duty for the last couple months. I can't wait to get back out there and get to use it for the first time. So
it's safe to say with the blood transfusions, with this ventilator, that patients' chances of survival, like calling EMS now, your chances of surviving is greater than it has been. Like there's been drastic improvements this year.
Absolutely. So with all the technology and new innovations that we've been utilizing here in the division, this is more like a mobile intensive care unit than it is anything else. When people think of critical care, what we do is take the hospital environment and bring it right to you. We meet you where you are. And then the continuum of care is even better, and the hospitals are absolutely ecstatic as well, because it's a lot of things that they don't have to do once we arrive because it's already been done.
So about this device, is this going to be kind of mounted in the ambulance, or is it something like a paramedic can take, throw over their back and bring into say a nursing home or an apartment building if they need to go somewhere to meet someone?
Both. We have a carrier, which is
right here.
This bag here, and then what you see, these gray arms, there's mounts inside of the ambulances that can be mounted on.
You can also put this on the cot as it's going, hook it up on maybe one of the rails or something, and it just moves right with the patient. Is
it battery powered?
Yes.
Yes. It's military spec battery. These are used in the Air Force, in the military. It has to have 8 hours of charge because these ventilators have to move from Germany to the United States on an Air Force flight. So that is a standard military spec on these ventilators.
I'll do one more show and tell.
Sure. Would you like me to not do it so fast?
I'm just gonna say, do it as slowly as humanly possible.
If you want to move,
Yeah, we'll move on.
if you guys want to.
I wanted to show you what it was like in real time so you see just how fast this is. We have a few settings on here we can do for adult. We cannot use this on kids, by the way, for the state of Ohio. So adult invasive, which means we're breathing through a tube, and then we have the non-invasive, which is the BiPAP and CPAP. So these are our circuits. This is called a circuit. This is where we hook our patient up to. These are 2 tubes, feedback tubes, and we always have it hooked up to high flow oxygen. So step 1 is always hooking these up. We're going to turn it on, and you're going to have a screen that's going to pop up here that's going to say, how do you want to use this ventilator? So I chose adult, which was an adult invasive with a pulse. I have to hit the green button. And then there's 2 checks that I have to do. Because we're in volume mode, I need to make sure that if I have a high or low pressure alarm, it's going to tell me. So it automatically does the first test there. Every time a paramedic turns this on and uses it as a patient, they have to do these 2 tests. Once those tests are done, I'm gonna dial in my parameters based on the ideal body weight from ARDSNet and oxygen. So we're really only making 2 adjustments. My tidal volume, which is probably one of the most important things so we're not harming our patient. We do the touch, turn, confirm. So if I want to do 420, 410, 400, I'm going to confirm that. I'm going to also change my oxygen level from room air to 100%. Once I do that, it's done. It's that fast. So if I can then hook it up to my patient, and remember, these patients are already being ventilated. So this is something that we are going to take our time to make sure that we do correctly every time. And then we hook it up to our patient, and it's pretty much quiet, very silent, very ease of use, and very sturdy.
Sergeant Moore, what is the minimum age that we can use it on?
16 years old. 16.
Set by the state.
Yes. Yeah, that's our scope of practice. Even if a 15-year-old or under is on a ventilator, the state says that we can take their ventilator if somebody's trained on that ventilator. But we're an emergency service, and they only allow ambulances to do it in non-emergency settings. There is also, if you guys want to see these are the masks that we use for the CPAP and BiPAP. So we would choose that setting on here, and instead of hooking it up to the lung, we would hook it up right to this mask. And then it's got an alarm because I hooked it up. See, what's really nice is if something happens, it tells us immediately. So this would just hook up to the mask, and then this would be strapped to the patient's face, get a nice seal on it, and that's how we deliver BiPAP and CPAP.
So what do you see, what do you anticipate our largest use of the ventilator would be?
I think we're going to see a lot of BiPAP use. We had CPAP in the past. I'm sure you've probably heard of CPAP from sleep apnea, but we use it for heart failure patients. But lung patients need 2 levels of air, one go in and one to back off so they can exhale more comfortably. So the BiPAP, I think we're going to be using it a lot. Obviously, that was the first call that we had. And as Sergeant Colson mentioned, we do have a lot of ventilator-dependent patients in nursing homes and homes. So this is probably going to be used for that as well.
Any last questions? Good. Just say your everyone's names again so they get it, because I don't know if we got everyone's names at the beginning.
My name's David Jockers. I'm a paramedic for the city and first vice president for CARE.
And I'm Commissioner Orlando Wheeler.
Rob Moyer, Sergeant for Education and Training.
Sharon Kozel, I'm a sergeant with education and training, and for the union, I'm the sergeant of arms.
All right. Well, I think, Commissioner, you wanted to take them on your way out by the recruitment class.
Sure. And I want to say in closing that when I started in 1994, up until today, our treatment of sick and injured individuals it's made almost a 360 from the equipment that we have and to the interventions that we can perform. We have made significant leaps and bounds in the care that we provide. So,
And just so for your own information, the 27 paramedics down there is our largest paramedic class in 13 years.